You know, in the high-stakes world of the emergency room, there's one procedure that every single person knows inside and out: CPR. The rules are clear, the training is endless, and yet, there's this really puzzling and frankly dangerous problem at the very heart of it all. Okay, so let's get right into it. The rules for CPR couldn't be simpler. Push hard, push fast, and don't stop. So if everybody knows the rules, what's going wrong? Why do even the best trained teams sometimes drop the ball? That's the big mystery we're going to unpack. And this quote it nails the entire problem. You don't lose a patient in the textbook. You lose them in the messy, chaotic reality of the moment. And that's what we call the knowing-doing gap, that dangerous space between what you know you should do and what you can actually pull off under pressure. So, to really get a handle on this gap, we're going to investigate 4 key areas. First, we'll uncover the hidden things that are stealing time and focus. Then, we'll look at some physical saboteurs, the patient's body, and you won't believe it, the bed. Third, we'll see what happens when the team system itself starts to crack. And finally, we'll talk about how to actually close that gap.
All right, let's start our investigation with the usual suspects, those sneaky little forces that quietly steal precious seconds and pull the team's attention away from the one thing that matters: getting blood to the brain.
So, enemy number 1 has a name: pause creep. And the thing about pause creep is it's not one giant mistake. It's more like death by 1,000 cuts. It's this slow pileup of tiny, innocent-looking delays that altogether can completely wreck a resuscitation.
And here's exactly how it happens. That pulse check that's supposed to be 10 seconds, it drifts to 12. Then someone says, hey, let's just get a quick peek with the ultrasound. Then the breathing tube needs a little adjustment. Then the pads are a bit off. See? Each one by itself seems reasonable. But every single second that hands are off the chest, blood flow to the brain drops to 0. It just stops.
Then there's what's called the center of gravity problem. Look, getting a breathing tube in is a big deal, it's technically hard, and it's dramatic. And it can become the star of the show, pulling the entire team's focus. And while everyone is watching the airway expert, the quality of the chest compressions can just quietly fall apart in the background.
It's the same deal with powerful tools like ultrasound. They're amazing, but only if they follow the rules. And the rules have to be strict. Ultrasound does not get its own personal timeout. It borrows time from the pulse check that's already happening. You get the probe ready during compressions, you grab one picture in a few seconds, and you figure out what it means after compressions have already started again. The minute the tool starts running the show, it's doing more harm than good.
Okay, but it isn't just about managing time and focus. Sometimes the physical world itself, the environment, and even the limits of our own bodies can be actively working against us. Let's be real, doing high-quality compressions is physically brutal. And the problem with getting tired is that your performance starts to drop long before you ever raise your hand and say, I'm tired. The compressions get shallower, the rhythm gets off. That's why switching out every 2 minutes isn't about being weak. It's a critical safety check. It's non-negotiable quality control.
And now for something that almost nobody ever thinks about. You're pushing on the patient's chest with everything you've got. It feels like you're doing a great job. But what if the surface you're pushing on is secretly stealing all your effort? So back to that question about the hospital bed. One study actually measured its exact impact, and the results, they really boil down to this one kinda shocking number: 64%. Now what on earth does that mean?
This chart explains it all. In this study, the medical team felt like they were delivering awesome CPR, about 94% quality. But when the researchers actually measured how much the soft mattress was squishing down, the actual quality of compressions reaching the patient's chest, it was only 64%. The bed was literally absorbing almost a third of their effort, and the team had absolutely no idea.
Okay, so we've seen how time, fancy tools, and even the furniture can mess up CPR. But the biggest factor? It can be the human system itself. Let's look at what happens when team dynamics and the whole environment just break down under all that pressure.
So here's the bottom line. Leadership is perfusion. Strong leadership equals good blood flow. Weak leadership, that's just chaos. You've got too many people shouting orders, no one knows who's supposed to be doing what, and nobody's watching the clock. But strong leadership, that creates order. You have one clear leader who assigns roles, uses closed-loop communication, so every command is heard and confirmed, and their job is to run the room, not get lost doing one single task.
And you have to imagine, all of this is happening in an environment of just constant noise. One big study found that in the ER, a monitor alarm goes off, on average, once every 30 seconds. That creates this intense cognitive overload that makes it almost impossible to focus, communicate clearly, and just protect the basics.
Which leads us to maybe one of the most dangerous traps in all of medicine. The room is buzzing with activity. Everyone's moving. Everyone's trying hard. Everyone's sweating. But like we saw with that mattress problem, visible effort does not equal good CPR. It just doesn't. Teams almost always think they're doing a better job than they actually are.
So if you can't trust what you see, what do? You have to measure it. The best teams don't guess. They use objective data, like capnography, which basically measures blood flow in real time. They have a CPR coach whose only job is to watch the technique and the numbers. They use little feedback devices on the chest. And, so important, they debrief after it's all over to figure out exactly where things went off the rails.
Okay, let's bring this all home. We've seen the problem. We've identified all the things that go wrong. So now, let's talk about the solution. How to actively and aggressively protect perfusion and close that knowing-doing gap for good.
And really, this all comes down to a fundamental shift in thinking. High-quality CPR isn't just a technical skill, like putting in an IV. It's an operational skill. The real job of the team leader is to build a firewall around the patient's blood flow and defend it from all that chaos that's trying to tear it down.
So what does that protection look like? Here are the rules of the game. Pulse checks are kept religiously short. The airway procedure does not get to dominate the room. You switch the person doing compressions proactively before they get tired. You fix the bed problem right away. And the leader? They lead. They stay hands-off and focused on the big picture. So in the end, the reason that good, smart doctors can perform bad CPR has almost nothing to do with them forgetting the right steps. The real barriers, the real enemies of execution, are all these things. The constant interruptions, getting fixated on one task, not recognizing fatigue, bad ergonomics, weak leadership, and just being completely overwhelmed.
And that really brings us to the final thought. This gap, the space between knowing what to do and actually doing it when things get crazy, that isn't just a problem in medicine. Think about it. In any high-stakes field, in your own job, on your team, even in your personal life, where does that gap exist for you? What are the subtle interruptions, the hidden assumptions, and the invisible forces that are quietly sabotaging your best-laid plans?